it will be joining me soon. And then we have a bunch of other staff who are just observing today. So.
Okay.
Great. Well, it's nice to meet all of you, at least virtually and at least just vocally.
Absolutely.
But at least we have voices.
And we might ask you to just let us know who's talking just until we start learning your voices on that side, and we'll try to do the same on our side.
Great.
And again, this is Christine. So I just wanted to briefly tell you about the purpose of this call. We just wanted to verify your responses that you submitted on your assessment tool, and based on those responses, we're going to ask questions to get a better understanding of your health center's current capacity as it relates to this project. And those answers will help us inform the development of your work plans and just how we work with you for the rest of the year. And throughout this call, we might also be able to identify some common themes between clinical and performance improvement. So after the two discussions, I'm going to give us all of us an opportunity to discuss if there are any common themes and ways that each of the two parts can support each other. So the next thing that we'd like to do, is give you a chance to tell us a little bit more about Adelante and why you're interested in this project. And there's actually one thing in particular that I'm interested in. I noticed in your application that you mentioned that you had applied to be a Ryan White Part A subcontractor. So if you can, during your explanation or discussion of why this project, if you could also just give us an update on where that application is, that would be wonderful.
Okay. So you would like us to start there then?
Yeah, sure. Please.
Okay. Well, to answer the Ryan White question right up front, to make sure that we do have clarity, we have had a change in direction on Ryan White and have decided to, we were a finalist and assessed some of those needs at this point from the organization and decided that we would pend that program until next year's application cycle. Here in the county, they're going through some changes, and we would have to reapply next spring, right at the time we'd be getting the program running. And with this training assessment and this planning year, we thought that would set us up to be much more successful with Ryan White in the next cycle. So the Ryan White piece is really, not in the 2012 plan. It would come into place in the 2013 or beyond.
Okay. All right. Thank you.
So a little bit about Adelante, a little background. Is that what you're looking for?
Yes, please.
Okay. Well, my colleagues certainly can jump in with me. We are a federally qualified community health center serving the Maricopa County, which is Phoenix metro area. And we started as a migrant health facility serving migrant farm workers back when this county was largely agricultural, in the rural areas especially. And we've since evolved to serving the new community that exists in Maricopa County. Today we're serving just under 30,000 patients in 7 locations. And we serve everything, the entire lifespan from OBGYN, pediatrics, family practice, internal medicine. We have dental services, beginning to integrate behavioral health services this year, pharmacy, lab coming this year. We just opened a comprehensive health center in one of our locations, a 40,000 square foot evidence-based design health center we're really proud of. And this year we'll be opening a second comprehensive health center on the other side of the county. So we have about 250 employees, about 30 providers on staff, and we're growing. So we're really excited about taking the next steps to HIV education and support in our community, because it's an area we have not gone into yet, and it's been part of our strategic plan. So this ties very nicely into the services we want to be able to provide.
Okay, thank you very much. Does anybody else on staff have any questions? Okay. Well, then I'd like to then get started with the clinical training needs assessment. And Mona, and I know we had a couple of questions, but I'll let you get started.
Well, what we would do is we would go through, we would just go through the form exactly as you answered it, and there are a couple of things that we wanted to clarify, just to be sure. You mentioned that you don't have any HIV patients.
As far as we know, we haven't obviously coded any in our system because it didn't show up in our UDS data when we pulled that. I can't be positive that some of our docs aren't seeing patients not for their HIV care, but may have either mentioned HIV in passing or whatever, but it's not anything that we know that we're providing at this point.
Right, but you're definitely not managing any patients for their HIV.
Correct.
Yeah, okay. And something that is, I would just really like you to clarify is you say that you don't plan to involve any of your sites in the HIV training. That's the question.
I think that's incorrect.
Yeah, okay.
Thank you for catching that. Yes, what we'd like to actually begin at this comprehensive site that Tiffany mentioned. We have a physician there. This is our surprise location. We have a physician there, Dr. Lucia Soto, who just finished Mayo Clinic residency.
Mayo, yes.
She did do HIV care there as a part of her residency. Actually, she believes she's seen enough cases to qualify for the requirements of her certification, and so she's going down that track right now, trying to get
for the AHIVS.
I'm sorry.
Because you mentioned in the application, not in this assessment, but you mentioned that, and I'm assuming now that it's her who is applying for her certification. But do you mean for her AAHIVS, HIV specialist certification?
Yes.
Yes. Okay.
Yes.
Great.
Now, she hasn't taken the first step. She just gathered information, found out what the requirements are, trying to gather, cases and whatever to support that application. But that's her intent, to try and complete that by the end of the year.
Yeah, well, we know quite a bit about that process. There's two different tracks that you can go through, so we could talk at a separate time. I'd be happy to talk with her about that.
That'd be great. That'd be a big help.
Okay. Okay, good.
And then we also have a couple of other providers in our system who are interested in getting education at other sites, and what we anticipate is trying to get this off the ground and then, spread this out to other locations so that eventually we have it across the organization.
Well, that leads right into the next question that I was going to ask you, because question 4 about the care team, it's very unusual for us to get, on your application, you listed a very, very substantial number of 18 MDs, 6 specialist MDs, 6 mid-level, and so typically people would have included more. We do what's called a whole site training approach, and so all of those levels of clinicians that we included there, we normally expect or encourage sites to include some of their clinicians from each of those categories in the training. We weren't sure if that's something that you would be willing to consider. We rarely would just have a site that has one clinician.
Right, and what I would like to do is, because so far I've gotten responses from 3 other clinicians who would like to be involved in this. We also have a nurse director who is not focused on HIV care at all, but has experience in the area.
Yeah, she's your patient experience director. Is that the one?
Right.
Mm-hmm. Yes, I was hoping that you would be including her. Thank you. I didn't mean to interrupt.
Tim.
Tim.
But in any event, we're kind of assembling the people that we want to get involved in this, but part of that was dependent upon our conversation today, because I didn't introduce myself. This is Bob Elk. I'm the only guy here, so when you hear my voice, I wanted to get more clarity into exactly what the teaching is going to be, the format, the frequency, kind of the whole construct around that. I don't have a lot of clarity into that at this point, which it looks like a lot of it is going to be virtual, and the PAs, the NPs, the other docs who want to be involved in this, then hopefully would be able to participate rather than gathering a lot of people from our widely disparate sites. The county is the size, of New Hampshire or whatever, and getting everybody together is very hard. But if we can do it virtually, then we can involve a lot of other people.
Absolutely. So we'll just say that the care team composition is a work in progress, and we actually have a separate call planned, and we can tell you when that is, when we were going to go into the details of it's called the training package and how we do the training plans, because this call is quite lengthy just to get through the information that the assessment form application. If you have time at the end and you want to stay on, I'll be happy to talk with you, but we typically have been scheduling a second call when we would send materials out to you in advance, and then we would be able to go over step by step. And it would be fine for us to do your care team composition review at that time.
Excellent.
Okay?
Yep.
Right. So that was what I was wondering, is your application had such a large body of clinicians to draw from, and it wasn't there. Now the next piece that we're looking at is the capacity, number 5. And we tried to explain the categories for the model of care and the stage of integration of HIV. And based on the, excuse me? Okay, based on the information that you provided to us on both of these documents, I wasn't quite sure if the collaborative stage 1, which you had selected on this form, is where we thought, would you be flexible to discuss also the model of care and the staging in the future?
Of course we would. Let me tell you our rationale for selecting that. We're not doing HIV care right now. We're going to have one, maybe 2 clinicians who are going to get trained this year. We have available resources through the University of Arizona to do some mentoring and to reach out for decision-making, in the moment. But we don't have the knowledge, the experience, of the training on site. So it seemed like we want to do some, but we're in the early stages, so that just seemed like the right fit. But if you have better insight into that, we'd certainly be open to it.
Well, I don't know if it's better insight, but typically, with the information that we have, we would say external and foundation, but with the potential to move really, really rapidly to collaborative stage 1.
Sounds good.
Okay. Okay. And the rest of it is very straightforward. You did talk about your clinician who had done her Mayo Clinic residency in HIV medicine. I thought that was great.
Wait, let me clear up what you just said. She didn't do a residency in HIV medicine. She did a residency in internal medicine and had HIV care as a part of that.
Okay. Okay. Yeah, and you recognize the University of Arizona AETC as a potential source of local training, and as part of our training plan, we would help you get that organized.
Great.
But it didn't seem like so far you had a lot of prior HIV training exposure among your staff, other than that one individual. So we can really help to strengthen that.
As long as you interpret not a lot as 0.
Yes. Yes, something like that. Yeah.
He likes to be very accurate, our CMO.
That'll work. That helps. Yeah. So, okay. So, in order to really talk about your training plan development, which will be the second step after we finalize the care team and explain all the package and the process and everything, you mentioned now that you only have a quarterly meeting when your your providers get together.
This is
on a Wednesday.
The entire medical staff gets together once a quarter. In between those meetings, we have departmental meetings of OB and family practice and internal medicine, pediatrics. They meet also about once a quarter. And then we meet in smaller groups kind of as needed.
Great. So then there's a lot of opportunity to put together a very well-tailored to your setting training plan that's site-specific for if you do decide to do 2 sites, that doesn't require everyone to be together, and that also builds a lot on the self-study part. We have a very strong self-study component.
Great.
Yeah. So really, the only other burning question that I had related to, and you do describe this much more in depth in your application, is how you would be generating HIV patients. You know, we can get started on the training so that you'll be very, very ready when in fact you do open the floodgates and your patients start coming in. But we thought maybe we would be able to help with some strengthening of your HIV testing, because right now it appears that you're not doing universal HIV testing.
We are not doing universal testing. I think it does vary a little bit from clinician to clinician. I think many of us are testing adults, you know, conformance to national guidelines, asymptomatic people, just screening, but not universally. We don't have anything in place that every person who walks in the door gets an HIV test at least once.
Well, you know, that's not easy to do quickly, but we can certainly help you to move forward toward the CDC guidelines, which is universal testing. There's a lot of barriers, but they're all able to be surmounted.
That's
and then
great.
That way, yeah. Do you know what the HIV prevalence is in your area? I think you said something like 4.
No, I don't know.
400,000?
I don't know what the prevalence is in Maricopa County offhand.
All right, we'll find that out, and that'll give us some good background information in terms of how many likely positives you would expect if you increase the amount of HIV testing that you do.
Great.
All right. Actually, that's all that I have right now, and we could turn it over to Mazdak for the second half of the call, and then depending on your time at the end, we could talk a little bit more in detail about the training. Just depends on your time. I would like to offer you, though, a choice of 2 different times when we're going to be doing the second call that we have scheduled. And if we don't get a chance to do it today, I'm just getting my calendar.
Because, yeah, we do recognize that we need to go a little bit more in depth about the project offering, so you have a better understanding of what we'll be providing.
Yeah, we might be able to do something individually before, but if not, we are offering noon on March the 12th or 10 o'clock on March the 13th. And at that point is when we were going to send some materials out to you in advance and then discuss any questions. But since you need to have some sort of more in-depth information, I think, to get your care team together, we might be able to talk a little bit more earlier.
Just a clarification, the times you gave, is that Eastern time?
Yeah, that's our time.
And is it a 1-hour call?
I don't anticipate it would be longer than that unless people really had a lot of questions.
Okay, so that would be 9 a.m. Let's see. When does daylight time switch? I don't know.
It's early.
Is it
The day on the 11th, the day before, actually.
Okay, so that would be 9 a.m. on the 12th or 7 a.m. on the 13th.
Oh, no, we wouldn't want it to be, no, I don't think 7. Do you think you could do the 12th? And if that doesn't fit, you know, we were going to do some groups of calls on those days. But if it doesn't fit, we'll make an individual appointment.
Okay, well, let me figure it out, and then we can get back to you and talk about it.
Right, okay. And so I'm going to turn it over now to Nasdaq.
Okay, and Nasdaq, do you have control?
I think I have control. Let's try.
While we're transitioning speakers, our CEO has joined, so I want to allow her to introduce herself and join the group.
Oh,
Hi,
good.
everyone.
Hi, just in time.
Hi, this is Aveen Tafoya. I'm the CEO at Adelante, and my team has my full support, and we're very excited about continuing on our path in our strategic plan to include HIV services and prevention and all of that good stuff as part of our overall patient-centered medical home offering.
Great.
Okay, and
Great.
this is Vanessa Rudin. I'm joining MASDAC. Actually, I've been on for quite a while, but didn't want to interrupt. So.
Hi, Vanessa.
Hi.
Hi. Now,
Hi.
was there anything specific that you needed from me in terms of where Adelante is and
Well, we did start off by just asking a bit of background about Adelante to give us a better sense of where you're located, the type of patients that you see in the location, and also I had a follow-up question about the Ryan White application that you wrote about in your application, and I think your staff has provided an answer. It seems like you've put that on hold, and this project will help your application for the following year in 2013. Is that correct?
Right,
Okay.
and that was our goal, was to immerse ourselves in the learning and planning and foundation building before we actually went forward with delivering services. We know that we have some physicians with that interest, but we want to be well prepared, and as you know, the community here, well, you may not know, but the community, the HIV services and outreach community is very strong in the Valley, and I've worked with them for 12, 13 years. So once we've got our foundation built, I think the collaborations in the community will come naturally, but we want to be sure that we're well prepared and able to deliver the services at the highest level.
Yeah, great, and we look forward to being able to support your health center's efforts.
Thank you.
And Javier, our project director, I believe, has a question.
Hi, Ms. Tafoya, is that what your last name was?
Yes.
This is Javier Salazar. I'm the director for the AIDS Education and Training Center, National Center for HIV Care in Minority Communities. Long name, but I'm so pleased that you were able to join us, and I can't reemphasize how important your role is in helping to move this work forward, and in offering your support. What we have found in the past in working with other health centers is that when the CEO drops away, a lot of the work also tends to drop away among the staff. So again, we really appreciate your support and your engagement on this, and we hope that we can provide you and your staff the needed support so that your health center can meet the needs of this community and can continue to be successful.
I appreciate that, and I want to underscore with you and your team that we are a little different at Adelante, and we have a pretty cohesive and shared leadership model, and
Wonderful.
I can say confidently that my team is as engaged or even more engaged as I am and the board in this work, and so I've got a lot of confidence that, with or without me in the room, that this is a group that's very mission-focused and wants to serve and have the results reflect the work and the energy that we've put into this program. So you're in good hands.
Excellent. We're excited, and we can't wait to meet all of you.
So this is Mazdak Mazari. I am a project manager with the Primary Care Development Corporation, and we are working closely with the AETC, NC, HCMC, totally a mouthful, but I'm getting better and better at it, to work on the performance improvement portion of this project, knowing that clinical transformation does not happen in a vacuum, and so really wanting to support the clinical objectives that you all are trying to meet on the performance improvement side. So I did want to start off by saying too that I know that sometimes during assessment processes, health centers feel like they have to put their best foot forward, and I just want to assure you that you all have already been selected for this, so we're not going to take away your participation. And so really it would be great if you all could be honest about what areas you feel like you need the most support around in terms of performance improvement. So does anyone have any questions or comments around that before we get started?
No?
Okay. And I did want to say we were actually very impressed with a lot of the processes that we saw described in the application. So it sounds like you guys are doing a really great job there. What we're going to do is Vanessa and I are going to switch off asking questions about the different sections and really trying to figure out from you where we can best help. So we're going to start first with revenue maximization, and I just want to highlight that we were really impressed by you have one of the lowest percentage of rejected claims that we've seen at 2%. I wanted to ask, is that 2% the percentage of the rejected claims, the total rejected claims, or once the resubmission has happened based on denied claims?
The information that we got from our business office was total rejected claims. The one asterisk that I was trying to put in the response, but as you know, it was set up in a table format, so I couldn't add free text wherever I wanted. I'm sure that was purposeful. But the asterisk we would add, if we could have, was we have transitioned to a new health information system effective February 6th. So we do have, right this moment today, we have some claims issues that we are trying to resolve in terms of how things are moving from the health center delivery site through our billing process. So that 2% was, prior to our next-gen transition, and
Gotcha.
We expect that it'll get back there, but today we do have some, challenges, as you would expect, with a brand new health information system, and we're trying to uncover those barriers.
That was very brave of you to transition.
That was
full transparency.
Yeah, no, that's great. What sorts of support are you all receiving or would like to receive around that transition?
It's more from our vendor and our next-gen, systems team. I don't know if it's necessarily part of this initiative.
No, yeah, it might not be. I was just interested in, because it might impact your ability to be reimbursed for working with HIV-positive folks living with HIV.
We can go back, and if you've got some field inquiries that you want us to explore, we can submit those questions to our trainer in-house, because I know that some of that information needs to either be preloaded or sequestered in a template. And there are HIV care templates out there. Certainly some of our health centers, sister health centers, are already using those formats.
Okay. We can discuss that further not on this call. But great. And the other strengths that I saw was it was great that you all provide regular trainings for your clinicians by professional coders. And also it just seems overall that the billing system is really robust. And so we couldn't find a lot of areas for growth based on what you put into the application here. I'm wondering where you see the most area for growth in this area.
Bob, Kathy?
Well, I'd say one of the things is that we're in a huge growth phase right now. A year ago we had probably 20 providers, and now we're at 37, and I would anticipate probably by the end of the calendar year we'll be closer to 50. And so when you bring that many people on that quickly from a lot of diverse environments, some just out of residency, some who have been, working in primary care for years, you have a wide variety of coding knowledge in that group. And so being sure that each one codes appropriately and it follows the norms, either under or over coding or improperly coding, that's a challenge for us. We had, prior to this, a fairly stable provider group, but now because of our growth, we see challenges in that. I certainly do, in trying to educate everybody for the same thing along with the other 94 things that we have to do to educate them clinically and in every other way to the organization. So that's my biggest challenge, I think, is being sure that they understand and getting them the education they need.
Can you describe a little more fully that process, how you've done it in the past around training folks and how you anticipate with these greater numbers, how are you going to do it as people come on?
What we've done in the past is have a group come in, a consultant group from the outside, coding experts, come in and give us presentations with handouts and PowerPoint stuff and little quick guides that people can take back to their offices that explain some of the common pitfalls and where people need to go with appropriate coding. That worked pretty well with a group of about 20 people in the room. It's hard for us to even find a room now for our provider group because it's so large, and doing that, once a year or so is not sufficient. So I am doing it more one-on-one as they come on, giving them handouts, sending them emails, trying to correct some common misimpressions about coding and trying to create some uniformity. But it's difficult.
I can imagine. So is one of the potential objectives in this area, and after we go through all the areas, we'll help prioritize which ones you want to focus on first, but would be around maybe potentially identifying best practices from other health centers with large staffs around how they train up their staffs around the billing and the coding?
Excellent idea.
Yeah.
Okay. Anything else in this area that you all think would be beneficial for you all?
I think one of the helps we'll have is the next-gen tool itself, because E&M coding is fairly formulaic. As long as the data is in there, it has a logic of suggested coding in there according to current guidelines. So it doesn't help a lot with the diagnosis coding, ICD-9, CPT, but does in terms of E&M coding. So that's been a huge challenge in the past. What will become easier now that we have this tool.
Great. And I also know that you all mentioned the HIV templates, and I think that NextGen does have a lot of that stuff available as well. Okay. So I think I'm done with this section unless you all have anything to add around revenue maximization.
I just have one question. How does the FQHC reimbursement work in Arizona? Because it's a little bit different state to state. Whereas in New York, it's definitely capitated for FQHC primarily.
Yeah, we're a prospective payment system state, and we have a wraparound rate that we submit costs, included costs, and we receive a rate per encounter for our Medicaid patients. So it's a little better than New York State, but it doesn't include all of our costs, obviously. We complete that reconciliation process every year. And in terms of a difference between, HIV patients and other patients, it all sort of comes out in the wash because we include a lot of those clinical services and enabling services in that rate.
Okay, great. Thank you. That's what we wanted to get at. Okay, is there anything else on revenue maximization?
Doesn't look like it from this group.
Okay. Mazdak, do you mind driving the WebEx?
Not at all.
Okay, that would be great. Thank you. Okay, so we're going to go on to quality improvement. First of all, I was very impressed with the documents you sent, both the minutes and your quality improvement plan. We certainly see a broad range of quality improvement planning with the health centers that we work with. Sometimes very good in quality improvement, but not documented in the way that you've done it. So kudos to you for being that advanced. So we noted that your two goals that you stated were increasing testing for all adults as recommended, the universal testing, and improving care and outcomes. And I was wondering if you, and you may not at this point, and that might be why you signed up, but if you have ideas of more specifically how you want to improve care and outcomes for patients living with HIV?
I mean, really it amounts to this grant and the training. We can't hope to provide good HIV care without the foundation that hopefully this training will provide us for not just the docs, but the organization. And so we just saw this as a very basic foundational step for us to move forward, rather than just open the doors and let it happen, you know, without the appropriate screening, training, coordination of care, all the things that right now are being provided in Maricopa County by a clinic that's been doing it for years and years and years. And we want to provide that opportunity out in the other areas that are not central, where patients don't have to travel across the county to get services.
That's great, and that's, I think, one of the reasons why HRSA in the first place is offering this, so we're really glad that you signed up. So I guess I've noticed in your quality performance improvement plan that you have approximately 5 stated objectives, and maybe you have others and it was too lengthy. Are you looking to, for example, include some kind of measure of how you're doing on universal testing in your quality performance improvement?
Our quality plan doesn't include all of our quality objectives,
okay.
which are around the UDS measures that we report on every year. And like we know, there's a whole new set that we just have baseline data on now, and many that we've been measuring for the last 4 years. And so we couldn't include everything in the plan. We didn't want to make it that comprehensive. We wanted to cherry pick across clinical and satisfaction values, something to demonstrate that we're going to have some specific outcomes. But that said, we have other things that we're also focused on just in the clinical area. For example, our entry into prenatal care, our asthma rates are pretty good, but could be better. Hypertension we put in the plan because we knew from historical reasons that we needed to do better on that. But diabetes needs to be better. So that said, in this area with HIV, I would see the major goal to be one of universal testing. I think if you don't start there, you can't hope to succeed.
Okay, and so that would be you're looking to formally include that in your list of, not necessarily in this plan, but in the list of measures that you're following.
Yes, and what we need to do is get a baseline data, because I have no idea how much testing, you know, it may be greater than I'm even imagining because we don't measure it.
And I think there's real opportunity with our implementation of NextGen, again, because it's such a rich database. We have a plan for a patient registry next year, which we can also mine for that type of specific outcome measure. So I agree, we've got to start with a baseline or a foundational number, and then we can incrementally have some goals to improve that going forward.
Okay, and since you've just converted to a new system with, you know, NextGen does have strong reporting and ad hoc reporting capabilities, is your staff, I assume they're recently trained in that? Do they, I guess maybe my question is, they probably were quite expert, I think you had Vista before, and now they're training up on NextGen, which, you know, actually, it just happens that many of the practices that I have worked with happen to have had NextGen. So I guess, now that you've actually already implemented, do you still have services from your vendor in terms of reporting support?
Yes.
Yes, and we're part of a health center controlled network here in Arizona. So there are several health centers that have, I mean, El Rio has a very strong HIV service component, and I believe they have an HIV health center, a focused health center. So they're in Tucson, it's a couple hours away, and we can certainly network between our health centers, both on the data end of things and the EHR, and the delivery of care.
Okay, great. Okay, and then in terms of having measures for care and outcomes, I'm kind of reading into this then that part of our work together would be to help you develop which measures you want to focus on in support of the clinical training and treatment. Okay, great. So then you're looking at question 28 about Oh, no, I'm jumping. Actually, that's Mazdak's going to handle that one. So
you can go ahead and start if you want.
Okay. All right. So sorry, I was just jumping into it, Mazdak. You noted that you've done PDSA methodology with your staff, and you've had mixed results. And I wondered if you could talk a little bit more about that.
Well, we've participated as a health center in the collaboratives that HRSA sponsored since 1998. But with staff turnover and leadership turnover, we've had some loss of that institutional knowledge. So we've really, restarted that with our Joint Commission accreditation and our patient-centered medical home survey process.
Okay.
But that process of, the quick studies, the PDSAs, is pretty common knowledge, I think at least amongst our clinical teams. So it wouldn't take a lot for us to introduce that with an HIV focus.
And I think that's another area where we could benefit from you and the learning
and technical assistance
in reintroducing that, because
right,
some of the leadership that was guiding that has moved on. We're hiring I'm hiring a new QI director with a lot of experience in quality improvement and process improvement, but not in this focused area. So your help in us learning that would be much appreciated.
Okay, perfect. And then let me just jump back to the quality improvement side. I was wondering how you, from your quality improvement plan, it seemed like with many practices that it's very much at a management level. And what we found with a lot of health centers is that upper-level management is trying to include frontline staff, and they'll post measures, somewhere that's visible. But when we work with the frontline staff, they'll say, I don't know what those mean. I know they're posting them, but I really don't know what they mean. So I'm wondering how you engage all of your staff, not just your clinicians, in innovating and reaching your quality improvement goals.
Well, I think when we started the Joint Commission process, we had a cross-functional team, and the Joint Commission planning committee was actually led by a frontline staff person, believe it or not, from our finance department. So I think that there has been inclusion of frontline staff. Now, whether you were to talk to an MA in our internal medicine department at Surprise and ask about all of our measures, I'm not sure that they would be able to talk to you about the whole cadre of measures. They'll probably be able to talk to you about our, flu vaccination rates and our diabetes A1C rates. And if you went to PEDS, they would be able to talk to you about their immunization improvement program.
Okay, so one's most relevant.
Exactly.
Right. Yeah.
I think we can do a better job of aligning, all of that with the knowledge base of each frontline person.
And I would
so it sounds like you're doing a really good job, and you might like help just sort of fine-tuning it and seeing if there's any gaps.
Yeah.
I would back off from that just a little bit in the fact that it's not just fine-tuning. I mean, one of my objectives this year is to really drive process improvement into all the front lines. Some of our sites are doing that. Some of our sites are working on the patient throughput process and improving that, and iterations of trying something, failing, trying something else, measuring it again. And other sites of ours are not involved in that with cross-functional teams. And so not just on the clinical, but on the patient satisfaction and the wait times and everything else, I think that's something we still have some ground to gain on and need to work more on. And so isolated, yeah, we're doing great. Across the board, I think we still have some things to learn.
Okay, so we can definitely, go ahead.
Coming up.
Okay, it's coming up. I would agree with Bob and say that concept of the cross-functional team replicated at the site level is really important to the success of a program like this. we certainly had that experience when we looked at our immunization rates, a decade ago, and they were abysmal. And the ownership of that frontline staff is really the only reason it's made any movement, especially in our larger sites. It's really owned by a key MA at those sites. So
at each of the sites.
I think also that they may, if we asked the frontline staff about quality improvement, they may look at us like, I'm not sure, but if you ask them, well, what are you doing specifically for the patient in terms of documentation or in terms of wait times or your interactions or the immunization rates, they could answer that. I don't know that they necessarily see it as, I don't know that they necessarily understand the language of quality improvement. The OB staff, they understand the importance of getting our moms in during that first trimester, the documenting of that, the UDS information. So again, sporadically, I think they all have a part. I don't know that they identify it as quality improvement.
That's a really great point, and I think one of the things we can do once we start working with you is identify if that's a worthwhile goal or not, is sort of how is it talked about in terms of quality improvement terminology and at a more abstract level, because that way, if you choose to go that direction, it's probably easier than they'll know what is being talked about at staff meetings when you bring up that information. So. Great. Well, that was very fruitful information for us to be able to think about a work plan that we can develop with you. Mazdak, do you have any other questions on the Plan, Do, Study, Act or quality improvement side?
The only other question I have is if you all can please talk a little bit more about how you use lean process improvement, what your history is with that, and how.
This is Tiffany. It was very minimal last year. We had a staff member who was our project manager across the organization, and we kind of dipped our toes into that water as an organization with the project managed organization approach. So very, very minimal. And as Aveen mentioned, we've had a number of different folks through our quality programs, our operational leadership, who have kind of started us on some of these paths. And that's one that, is not part of the organization really today, the lean process. The concepts, yes, but formal structure, no. And Kathy has some background, as do a few of us, in a number of other different approaches, but, I wouldn't say that lean process is part of the organization today.
Okay.
I agree. I think there is an opportunity with reintroducing that and taking, for example, we mapped out patient flow when we were doing our research on our health information system transition. And so each and every employee in this organization was in, a conference room with a consultant looking at the, minor steps with Mercedes.
Not every employee, though.
It was just about every employee. It was all of the clinical employees at that time. And they mapped out the entire patient flow and then went back in and looked at redundant processes or processes that could be collapsed with a new EHR. And so I think that there's an opportunity there because there are enough of those employees still here that we can talk to them and say, remember when we looked at this is how it might apply to a particular clinical improvement process. Because we spent a lot of time and money on that initiative, and, Tiffany's right, we did not maximize the spend, and it didn't stay with us in terms of the language and the work that people do today. But if we pulled some of those key players back into the room and said, you remember when we mapped this out and how we looked at redundant processes or collapsing inefficient processes, I think you'd have something.
Well, and this is Kathy. I actually taught lean for probably about 4 years in my previous world, and so I take those concepts when I'm meeting with staff and really just use the basics. And I always let them know that for me the basics is just reducing waste and increasing value. and that in everything we do, it has to be patient-focused. So I take those three concepts, and when I'm working with somebody, whether it's a frontline MA or a coordinator or whoever, and just say, you know, in your day-to-day, how do you decrease waste? Is that, you know, is something as simple as, you know, is the equipment that you need within reach, or do you have to walk, you know, all the way down the hall to get that? Or is there a better way to stock a room? Or is there a better way to collect the information from the patient? So I think that we are in spurts, I think are reinforcing some of the lean concepts without saying come to a lean class, but let's think about those concepts.
So it sounds from what I've been hearing that a lot of the foundational pieces are in place at the center, and it just might be a matter of being more deliberate and intentional about creating this culture of quality improvement at all levels, and being intentional about what kind of language we use so that everybody understands that. And that's definitely something that we can work with y'all on. Does that capture what you all were talking about?
Yeah, that's great.
Cool. Okay, anything else, Vanessa, on that section before I move to the next? Okay. So the next section is around cultural competency. And again, I think you all showed a lot of strength in matching. Sorry, go ahead.
Oh, I'm sorry. Go ahead.
Okay, in matching your staff to the communities that you serve. So I think that where I want to cover here is specifically around the populations that are most impacted by HIV in your community. And I'm wondering, geographically it's different depending on where you are, if you all have information about who is the most impacted in your county by HIV.
No, not really.
I'm not sure we do at this stage. That would be a step we'd be interested in learning more about.
Great, we can definitely. I heard someone say no one too, and it might be that the rates are really low, but that's something that we can explore.
We've heard anecdotal information. You know, as an example, our new Surprise site is surrounded by retirement communities over 55, the Sun City communities, and we've heard anecdotally that there's a population that needs our care and attention, senior population vis-a-vis HIV/AIDS, but we don't have any data that any of us, we're looking at each other, that any of us can really point to.
That actually, in New York City, that's been happening too, where there's an increase in senior populations, I think, for lots of cultural reasons. But that's the type of thing we would help explore. And then in terms of, have you done any, it's great, I think that it sounds like you all, for all new employees, do some sort of cultural competency training. And also, can you tell me a little bit about what's included in that and how that's going?
It's a web-based module that's part of our initial onboarding. And it ties into, you know, some of the basic safety training, you know, bloodborne pathogens, workplace safety, and then there's an additional module that's a cultural competency module, and it's, again, it's web-based, so folks can refer back to it at any time. We do it in a classroom setting here. We hire folks in groups or in classes of anywhere from, you know, 4 to 12 people at a given time. So it's facilitator-led and online at the same time, so we can stop and have some discussions. And our new employee experience director is also engaged in expanding that web-based module to really specifically discuss ways we can support that in our current population. So as an example, you know, we're largely Hispanic, both from a patient perspective and an employee perspective, but we're reaching new populations as Maricopa County has changed. So we want to have specific information about, you know, an Asian population, what some of the cultural competency factors might be, the senior population that we mentioned. She comes from another large health plan where we did some really great training with the senior population, and so she's incorporating that. Experiential learning into, you know, what it's like to be 75 and be trying to receive health care, from, you know, manual dexterity to eyesight to hearing to mobility, and putting our folks through that kind of experience so that they really are, you know, literally walking in someone else's shoes. Yeah.
That's great. I know that for a lot of folks that, did someone have anything else to add? I'm sorry, I heard
Well, with our community collaborations with the Southwest Center for HIV and the Human Rights Campaign, we're going to complete that survey this year. And we've got some staff that are, personally involved in a couple of community organizations in the LGBTQ community. So I think, the feelers are out there in terms of reaching out and acquiring that competency and that building that safe environment, if you will, to come and access care. But we certainly love more training and knowledge base. I think, that can't hurt.
Great. And I don't know if you all saw, but there's going to be an upcoming webinar around LGBTQ cultural sensitivity in healthcare settings that the AATC announced. So definitely make sure that folks are involved in that.
We would, I think we've got some folks signed up for that. And I think it's really important, too, for us, just as an organization, to be, a safe haven for caring not only for those who self-identify as LGBTQ, but their families. I mean, I've been involved in advocacy for, almost 2 decades, and I'm still continually shocked at the stories of the families of those individuals kept from, being involved in their family members' care.
Yeah.
So we're very committed to that, and we have a lot of board support around that as well.
Okay. And in addition to the trainings, has there been efforts to operationalize what you learned from the trainings to make sure that that sort of thing doesn't happen?
I think in terms of our policies, we need to update those policies. I mean, we obviously have our non-discrimination clauses in just about every policy, but I think we need to be much more demonstrative of including that sexual orientation or LGBTQ language, right? Because I don't think we have it that specific today.
We don't have any specific group identified. We've kept it very general.
Do you see that, has that been an issue over at your health center in the past with new employees coming on, or?
We haven't had any incidences or cases. In fact, I'd say we have a nice representation amongst our employees today. Certainly our hiring patterns, we've got a broad, diverse employee base. So I think we do a good job of reflecting the community that we serve overall.
Great.
Employee referral is our number one source for employee recruitment. So we've seen, an employee be hired who brings in their community with them, whatever, their community might be. And so we've really seen some nice progress in that arena.
Great. My final question in this area is that I know that you all mentioned that you're not sure exactly how much universal testing happens, and I know that one of the reasons that happens sometimes is because of provider discomfort in handling what they may see as a stigmatized disease or situation. I'm wondering if there's any training that you all have done with providers around similar issues to asking people about sexual histories or drug use histories and asking them to get tested or offering that.
I don't believe so. I'm new in this role for about 4 months, but I don't think I have seen anything in the last few years here around training of that nature.
Okay. Is that something that you all would be interested in?
I think so. I think it'd be great.
Okay. Cool. I think those were my questions. Vanessa, did you have anything to add?
No, I think you were very thorough. Great.
Is that code for very slow?
No, not at all. I
think
that was really, again, it's really great for us to get this information up front. So.
Yeah. And so the next section, I think, really relates to this in terms of recruitment and retention. And I think I know you guys do a lot of outreach to the surrounding communities, but we're I'm wondering if you've done any specific outreach around HIV testing around populations most impacted by HIV in your communities. And I'm guessing, well, I'll let you answer that.
I'm sorry, can you repeat the question? We had a beep in the middle.
It was just, was wondering if in addition to your outreach generally to the populations that you serve, if there's been any specific outreach to communities most impacted by HIV or HIV-specific outreach.
You know,
like, do folks know that they can get tested?
At this point, not specifically called out or identified, but certainly, and here's the final version on the screen, certainly the community-based outreach that reaches the entire Maricopa County area in terms of, you know, health fairs and community activities, but not a specific, you know, sign that says, get your HIV testing here, or, you know, something to that level of detail quite yet.
And that honestly might not be the best way to go either. We're just in working with you all to get more of the population at risk served by you all. We just kind of want to know what was going on already.
I think especially that senior population, there are some nuances to that community. It's similar to what we did, you know, 10, 15 years ago with the MSM population. They didn't self-identify, and so you needed to ask particular questions as a provider. You needed to, you know, create a safe place, and then they were much more open to engaging in that conversation at their doctor's office because it was familiar to them. And so I think we would benefit from a best practices sharing with other health centers who have sort of non-traditional populations that we need to get into and test to identify those patients. Would you?
Yep, I agree.
Great. And can I ask, I realize I assumed that the issue with the seniors was the same that we've seen here. I just want to check with that. Is it really around what we've heard here is many more folks staying sexually active longer than they may have in the past with the introduction of erectile dysfunction medicines, and then not needing to worry about birth control, so not thinking about protection in those ways, and then HIV and other STDs spreading in that way. Is that the similar issue?
Absolutely. Yep. And we have, remember, we're on the border, so there's a very strong, you know, sex trade community and, you know, a lot of trafficking from Mexico. And unfortunately, some of the things in my collaborations with the Southwest Center are, you know, that trafficking and sex workers with HIV then getting into that senior population who's now, you know, able to pay for that trade, and they're, you know, they're contracting HIV. So there's lots of interesting nuances because of where we are geographically, because of the populations, because of the availability of the ED meds. It's just really different than, you know, the things that I was involved in 10, 15 years ago back east. So.
Well, and the situation from a community perspective too is, in Surprise, we have senior communities. So you have a large number of folks living in the neighborhood. It's, you know, it's a gated community of, you know, 10 square miles, and everybody's over 55, and they have community centers and activities.
And they're active.
They're very active communities. But there's
active, however
you want to.
We're happy about that.
We're happy about that, but it opens opportunities, you know, and it opens opportunities for a lot more socializing than if the senior population was spread across the county. They're more concentrated.
Yeah.
And
well, and a need for more education.
A need for more education. Yeah.
Right, especially on those unsafe practices, because, you know, they don't have the same concerns as the younger populations or those in the LGBT community. So, yeah, I think for us, we'd love to learn from anybody who is doing well with those types of communities, and we'd love to test and institute ways of outreaching and caring for those patients.
Right. Okay, and we'll also try to do some research. I know sometimes that stuff gets overblown because it's so scandalous sometimes. So we'll try to see how much of an issue it actually is too in the area see if that's a good use of resources.
Great.
Agreed.
Okay, thanks. I think those are all my questions. And then I think as recruitment seems like the main area to focus on, and then as you all start seeing more folks living with HIV and AIDS, we'll also talk about retaining them in care, which is also a big issue for a lot of folks that are at that stage.
Great.
I'm going to pass it over to Vanessa again.
Great. So now we're going to talk about the next part, which is about access related to appointment access. And I've done a lot of work in open access and advanced access, so I was intrigued to see that you actually have tried an open access scheduling system and have strong goals about same day and third next available 3-day access. So my first questions are just, do you actually currently have same-day access for acute visits? I know you're measuring it, but do you actually, have you achieved it?
In most of our schedules, I would say yes. There are a few that may be out a couple of days, but overall, yes. We've actually built our schedules so that, understanding that we also have a fairly high no-show rate, that we have what we call overbooks, and those overbooks are not booked until the day of, and so they are for people calling in that day for any acute issues, or if somebody's calling in and even if it's not for an acute issue and we have the space, we can go ahead and use that slot, and that's about 4 to 6 per provider.
Okay, and so let me just make sure, I think I got it. So basically, unlike some places that have overbooks months in advance, you keep a clean schedule, but the day of, knowing that you have a high no-show rate, you are willing to do some overbook because you think it will balance out, and but you do it in as streamlined a fashion as possible.
Exactly.
Okay, great. Okay, and then it sounds like you're measuring that. Now, I know you just switched systems, but I'm just wondering if you can tell us a little bit about how you measure that.
I'm not.
I think we measure the overall appointments kept, but not by type.
Right.
Whether it's a pre-schedule or an overbook. I think that's a great suggestion, though. I'd be curious what our
I think by the end of the day, we look at how many appointments each physician had at the end of the day, but we don't, or each provider, but we don't necessarily break it down into acute or and what was scheduled at what point.
Okay, and you don't necessarily even spot check, like if I were to look tomorrow morning at tomorrow, how many actual open slots are there?
I would say that we informally do that, yes. That's kind of a work in progress with our folks that do the scheduling. In terms of what I'm working with them on is understanding to look at schedules more globally, and that when a patient calls and says, I need this kind of an appointment, that you just don't go to the next slot, but that you look at it globally to say, you know what, if Dr. Elk today has 20 patients on his schedule and tomorrow he has 3, then it would make sense that we put that patient on the schedule that has 3 and not 20. So really trying to look at how do we globally manage the schedules, having an understanding of making sure that we don't have one day that is packed and one day that's not. So that what I would say is a work in progress with all of our staff, understanding the importance of having those open appointments every day.
Okay. The reality check, though, is, and this is from the CEO perspective, this is not wearing my clinician hat. The truth is, when we had an open access scheduling system, our no-show rate was less than 10%. It works, we know it works, but we are rebuilding our provider leadership because we've gotten to a point where we've introduced so much change with the new EHR, and we've got new provider leadership that we really need that buy-in to be able to go to a true open access system. I'm bought in. I've been doing this work with community health centers long enough to know that what we do today is not the ideal, but I think we're making progress towards that. If we can catch up on the backlog and do today's work today, I think we would be much more efficient. But we're not there today.
Okay. All right. No, that gives me a good idea of where you're at. And you mentioned that you'd done OAS, but then you had difficulty scheduling. Do you want to speak a little bit about that?
Well, I think with the provider leadership changes, we had a new chief medical officer, and we started hiring new physicians who weren't used to that system.
Okay.
And as happens with, clinician types, we want to micromanage the appointment types. We don't want PAPs back to back. We don't want 3 new patients back to back. And so then it started to backslide, and we just never really recovered from that.
Well, the other piece was prior to our Kathy, our new director of operations, who's also in the role just in the last year, we had scheduling out at each health center. So with an open access approach, the phones were barraged. It was a technology backlog. Phones got barraged first thing in the morning. Patients couldn't get in. We lost opportunities to serve people. So prior to Kathy joining us, we centralized that function, pulled it all in, and added the infrastructure underneath it. So our system now can take thousands and thousands of calls in an
okay.
Allowing us to rebuild that open access approach.
That makes a lot of sense. Yeah, you have to have your phones work. We have to put your phones working no matter what. But granted, if you have open access, they need to work today.
Right.
And if you have no-show problems, your phones have to work, because if I can't get through to you quickly to cancel, I'm not going to bother calling.
Right. So that's that centralized process I called out in the response back. We have right outside the window, we're all looking at the screen right now. We can see across the entire organization how many calls are in queue. We have 18 reps who do all of our scheduling, medical records, and referrals, and they sit right outside the CEO's office, and they're trained professionals. Most of them are medical assistants, and they're the magic behind making this work now. So we're rebuilding that to Kathy's
That's great. I mean, we have a lot of expertise in that. To be honest, my assumption is probably that if we worked on that with you, it would be towards the end, and it would just be helping to set you up to restart. And the reason I say that is because normally you can focus just on open access for 9, 12, 15 months, and we've really ultimately only got about 8 months with you, and we want to be focused on the HIV part. So we'll have to figure out what part really fits the HIV clinical focus. But anyway, but it's good to know your background. So
if you've got, open access or other scheduling, gurus that you want to connect us with, though, I think that would be worthwhile, even for our patient support center team, to get connected with some of that training. I think it's really difficult to do that training in-house. It's really important for folks to see it working somewhere else, and to be able to have that confidence that they can make the transition.
Okay, great. I made a note of that. So,
thank you.
Let's see. So, I just had another question around that before we go on. Cycle time. Do you also ever check your cycle time?
We do. We actually just and we've done 2 of them in the last couple of months at 2 different centers, and we've got that information. We've made some changes in both of those centers. Once we identified where some of our leg was, we'll readdress that probably at all of our centers once we're through the next gen transition. Right now,
because that's you want that factored out. And what do you remember approximately where you were at either of those centers in terms of cycle time?
We're right about an hour in both, on average. Some providers much less, some providers a little more.
Okay, but in that approximate. Okay, so that's actually on the decent end. We certainly see places that are 2 hours or more. So, all right. So let's move on to reporting and population management, which we touched on a bit when we were going over quality improvement, but we'll dig a little deeper now. And then I think we also have to look at this from the perspective of your now and next gen, and would the answers still be yes? So maybe we can actually just go down each one. So does your health center have at least 2 staff members trained on how to navigate the analytic tool? So now I think this yes is probably about Vista. Is that true, or is this about NextGen?
That would be also NextGen. I mean, are the reports perfect and exactly what we want 2 weeks into the process? No. But
right.
We have a number of folks who are pulling data, every hour.
Okay. Well, hurry up. No.
The training is more rudimentary in NextGen.
Yeah.
We're just not high enough on the curve yet to really see the fruits of it. But they are trained in it.
Yes.
Okay. Yeah. I just want to, and again, as Mazdak noted earlier, given that this is not so much of a, let's see, you know how you can get reviewed and someone's going to judge you and then you just get it, but this is more for, okay, where do we need to focus and what's the timing? For example, if we're going to work on reporting with you, do we work on it with you immediately, or do we give a little time until your staff get up to speed, so now we're working with them where they were at in Vista but now in NextGen? I don't know the answer to that, but that's something that we should keep in mind.
The latter. We're hoping for the latter.
For the latter, yeah, because and it just depends. We can kind of tailor the work plan to that. So it says, is there a process for requesting custom support? So, I'm sorry, custom report. And so I presume you have that, and then I know there's ability to do that in NextGen as well.
There in NextGen, of course, if you're familiar with it, there is an ability to do a custom report on your own through the reporting module without someone going behind the scenes with a SQL query or a crystal report or whatever. But I've used NextGen before, so I know how to do that. Do we have that expertise broadly throughout the organization? Absolutely not.
No, and I think for our purposes, we'd be more likely looking to work with your reporting gurus to develop what you need for HIV clinical measures and process measures. So, but then it looks like you actually mentioned SQL and crystal reports. So do you anticipate using those in addition to the NextGen built-in reporting?
Yes, we do.
Okay, and some of your staff are trained or training up on that?
Yes, we have a very strong IT department with a lot of strength in that area.
Oh, great.
We have a dedicated business analyst or data analyst who's very, very, very strong on SQL database and is doing a lot of the queries for us now already.
Oh, perfect. Okay. Is there a process for validating the report? And you put yes. Can you tell me a little bit more about that?
That's some of the work we're doing real time today, and using the word validating somewhat informally. It's looking at the front end. A real time example is our payer mix or our patient appointments kept. Having the site leaders at the point of care actually doing that calculation, and then having our DBA that we just mentioned, our business analyst, running that report, and they're literally comparing the two. Almost line by line, almost patient by patient right now.
Oh, that's fantastic. Okay.
And we're uncovering a lot of interesting things, so there's a lot of momentum there.
Oh yes. No, that's actually, I know what you think you're getting and then what you're actually getting are not always the same with any EMR. So I think that's fantastic that you're doing that. So you're in process on that. And so basically whatever measures we do with you, we would be working through that process and then having some kind of monitoring to double check it so it doesn't, in 6 months from now, something doesn't switch. And then part of it, I'm assuming, there's sort of assumptions about fields being pulled, and there's also the data going into the fields. And so I'm assuming in your current process, then you're also working out the retraining of staff when things aren't getting entered consistently. Is that right?
Absolutely in process now.
Okay, good. Let's see. So then, yeah, I guess, sometimes you can get so many reports and it can get confusing, and then staff actually are confused about which report to use. So I'm wondering if you have a process for sort of listing what the reports are that have been created and sort of, just as you have to reconcile medications, reconciling reporting and making sure it's cleaned up.
I think that's a work in process.
Yeah, that's very, very, I would say minimal as of today.
Okay. I can't hear you guys. Oh.
An end of our fiscal year test run and review. I don't see that happening before we have data populated in that system. So I would say, yeah, it would be some time before that catalog would be generated.
Okay. Well, and the other thing is, since you're having to translate your reports to a new system, you indeed may, in that process, be creating a clean set of reports.
That's what we're hoping to do, yeah.
Yeah, I mean, it's more likely a year or 2 or 3 from now that you'd end up with kind of almost the same report 4 different times or something. So, and you report...
The same would go for 47 and 48. I think those are a no right now.
Okay.
Probably in 2013 we can revisit those.
Okay.
And then in terms of the registry, that's a 2013 because you've got to have data before you can develop a registry. So we have that on our strategic plan, that we would have a bolt-on software program that works with NextGen. That's a formal registry.
Capability.
Okay. Now, let me just back up a minute. You said you have to have data in order to have a registry. Are you saying that you didn't import any data, or are you entering data as patients come in, or did you?
As patients come in, because we had such a, well, we had, you know, our Vista implementation, and we abstracted everything. And one of the lessons learned was that probably wasn't a great use of our resources and time. So we made that adjustment with this transition. Obviously, we still have our database in Vista and our paper records for the OB sites that were not on Vista and went straight to NextGen. But we did not want data that we didn't have confidence in to go into our clean NextGen system.
Right.
So we made that decision as an organization because we're committed to quality.
Oh, great. Okay. So you could potentially, even if you don't have the built-on, if we want to do some registry reporting for HIV, we could do simple workarounds for the time being, using your current system and even potentially exporting to Excel or Crystal reports or something like that.
I think so.
Yeah.
Okay. All right. So, and it just would have limited data, but whatever data's in there, at least we would see that reflected in the reports so we know they're working.
Yeah, I think if you pulled that just from the codes, you'd know if you had anything to work with.
Yep. And you could pull by lab results, too, because we have electronic interfaces with one lab and now, hopefully shortly, with a second lab. So you should be able to create a query looking on HIV positives.
Yeah.
Okay. Yeah, and then also, since we don't think very many people have been tested, and if you're doing it going forward, then presumably that data would be in the lab interface and in your current diagnosis because you would be entering it. So, okay. And so you pretty much put no to the registries. I also just want to check in with you about our question 57 about panel or cohort reporting and studies. So by that, what we meant was, for example, if you were if you were treating HIV patients into a set of HIV patients in 2008, which you weren't, but just hypothetically, and you wanted to see how your treatment for those patients, or let's say you wanted to see if the change in CD4 count or viral load over time, that you would be able to just look at that set of patients, even though there are other patients since then that have been diagnosed, but you want to know how are those set of patients doing. Have you done that in the past? So we would call that, it's not the...
No.
Pardon?
We have not.
No, we have not.
Okay. So that's one of the things that we would love to be able to work with you on because it's something that a lot of F2HCs don't do, whether it's for diabetes or HIV patients, and it makes it easier to understand the impact of certain treatments or treatments over time. It also helps, if you can imagine, having a set of patients in 2008 and actually having really good outcome with them, and then another practice closing down and sending you all their patients, and all their data comes into your system, and when you average it all out for the entire set of patients, it doesn't look like you've had any improvement at all. And so we want you to be able to see your impact for a specific treatment more easily. So that's something that we can actually help you with.
That would be great.
Yeah. So MASDAC, that was kind of lengthy. Do you have anything else to ask or add, or?
I don't. I know we're getting towards the end of the time, and I think we've gotten enough to move forward with the work plans. Do we have time to recap the priorities, Christine? Or should we move into the last slides?
Let's move into the discussion quickly. And I mean, it sounds like we do have a lot of great work to do with you this year, and we're going to discuss next steps shortly. And what we're going to do on our end is help prioritize the activities that you've just discussed with PCDC based on the clinical training that we'll engage you on. So I mean, I want to give Adelante, I want to give you guys the opportunity to discuss any thoughts or reactions to some of the things that we've discussed today. Just with one caveat, just to know that we will be going into a second level of assessment for the clinical side, specifically with your providers that you identify, and we're also going to have more in-depth discussions about how the clinical training will be rolled out throughout this project. So did you have any thoughts or comments or reactions to what we've discussed earlier today?
I don't think so. I'm pleased with the spectrum of training and services and collaboration which you can offer.
We're ready to get going.
Oh, great. So, well, I mean, but let's talk about some priorities, particularly on the performance improvement, because we do want to make sure that your staff is able to still focus on the clinical training. So if you were able to prioritize some of the things that were discussed, and Mazdak, you might be able to recap some of the things that you've captured, but what might be some of the areas that you would want to focus on?
Would it help if we?
What?
Would it help if we repeated some of what we pulled
out?
Yeah,
please. Yes,
sure.
Please.
Okay, and Vanessa, feel free to jump in here. For the revenue maximization, we were really, there wasn't actually a whole lot under revenue maximization, except for, let me go back to my notes. You were talking about working with best practices for training large numbers of new providers on coding and billing, because I guess right now you don't have room to do it all at once. You've been doing it one-on-one. So if there's a way to get that information to new providers. For quality improvement, it was really around, there was something around driving the process of creating a culture of quality improvement at all levels and making sure that everybody feels ownership of that process, as well as really using a lot of the methods that you already have in your arsenal around the HIV clinical measures, particularly around universal testing. Was there anything else there, Vanessa?
I would just tweak it a little bit. I think it was culture of innovation and everyone being familiar and understanding quality improvement terminology that leadership uses, and then having specific people at each site have ownership such that they help to make it happen at each of those sites.
Thank you. In terms of appointment access, we really talked about just tweaking the work that you've already been doing around open access and potentially cycle time, but I think that was getting more into the nitty-gritty. Recruitment and retention was around recruiting more, doing more universal testing, recruiting folks specifically from populations that are most impacted by HIV to get tested. Around cultural competency, we talked specifically around finding out who's most impacted by HIV in your communities and making sure that your staff is equipped to deal with their issues. Particularly, we talked about seniors or LGBT populations, and then also specific trainings around how to deal with topics that might be sensitive, such as sexual health and substance use, to give providers more comfort in asking those questions as a way to do more universal testing. And then finally, Vanessa, did you want to recap around reporting and population management?
Yeah, I think reporting and population management, it's really going to be doing, going ahead and doing registry and panel reporting, but in a sort of what you guys would consider a workaround, given that you're going to go to a more formal registry reporting system in a year. For other places, it would actually be what they do ongoingly, but I think for you, it would be a workaround, temporary workaround.
Do you all, did we miss anything?
Sounds right to me.
Yep.
Okay, so out of those, what seems to be the most, like the 2 or 3 most pressing issues to deal with over the next 8 months?
Yeah,
I think getting quality improvement into the frontline staff and understanding the language and culture would be one. Second one for me would be rolling out education and maybe some sort of a default process for universal testing rather than it being dependent upon each doc with each patient ordering the test, but, you know, kind of screening that we could offer patients maybe even either with the provider or even taking the provider completely out of the loop, creating standing orders or something of that sort so that it might become more universal rather than, you know, changing provider behavior one provider at a time.
Right.
Those would be 2 biggies for me, I think.
Oh, totally.
And maybe the cultural competency one would be third.
That's a really good one, too.
Can I speak up from the clinical side here?
Yes, please.
Yes, okay. Well, one of the reasons that I suggested that we reclassify this organization as Foundation is because, Dr. Elk, Foundation does provide a real emphasis on getting the HIV testing process in place. And so I think that that's a natural kind of convergence with what you just said to us. And that when we have a chance to review the training package, I'll be able to show you in detail exactly the kind of preparation that that is involved in that. And it has both cultural competency and HIV testing in that foundation stage of training. And I also wanted to say that you've been talking a lot about ownership of the other aspects of the project work, and I think it's really important from the clinical perspective as well, because in fact, you know, from our point of view, the clinical training is the main reason that we were funded to do this project. And so I'm wondering if you feel that you'll be able to generate and motivate the same kind of ownership for the HIV clinical training part of the project, and whether there would be a champion or two that you might put forward who would help to get the same or more level of participation in the clinical training as in the other aspects that Vanessa and Mazdak were describing.
Yeah, I think, you know, we've identified an internist in our surprise location where we want to begin this rollout who has stepped up and said, I will be the champion. I will get certified. I will, you know, be the point of the spear, if you will, to helping the organization move in this direction. So absolutely, I think we have a champion, and she's done HIV care in her residency, and there's no reason why she can't be the change agent.
Yeah. Great, great. And I really think it's important that you gave your staff the opportunity to self-select into this program, because we've been finding that the most motivated and longest duration of people who are participating in the training are those who really, really do want to be in the training.
Sure.
Yep. And when we were recruiting her, it was actually part of the discussion, and one of her driving, or one of the pieces that drove her decision to join us was to be able to be involved in building this. So she's very highly motivated, and I think she has a good level of trust and respect given her, Mayo experience and her other professional background.
Great, and I'm wondering, I might suggest that perhaps when we do that second call to explain in depth the training and everything, that if her time allows, or if we even have to schedule a special time for your call, perhaps the two of you, Dr. Elk, could participate in that call.
I think that's a great idea.
Okay, good. Great. So are there any other comments or questions about what we've discussed today?
This is Vanessa. I just have one question just so I know where your vision is. If you didn't recruit from outside of who you're already serving, but mostly focused on getting the HIV training and making sure that there was universal testing, would you feel, and measurement and all of that reporting, would you feel very satisfied, or would you be, or is there also a heavy interest, and I'm not planting this, I just want to know which one it is, in actually potentially attracting other people who are not currently your patients, but who may need HIV services?
Yeah, I mean, I think we assume we are already serving some patients with HIV.
That we don't even know about.
No, I agree, but are you wanting to specifically do heavy outreach to other people, or is your first step just to make sure that those you're already serving are tested?
Well, I think, realistically, it's let's take care of our established patients, but we're very open to that outreach, especially in the communities we serve. Geography prompts a lot of community health center expansion, and whatever's going on in your community, you need to take care of. So I think we go in with that attitude. We've got a couple of new access point applications out there, hoping that they get funded, and they're in communities that don't have a lot of access. So I think with or without our new provider, we would need to address HIV in our communities. And that's been a board initiative that started with our strategic planning process over 2 years ago.
Could I ask, it's a bit of a detail, but we could just maybe very quickly, you mentioned that you have prenatal care, and I'm assuming that you do the standard at least 2 HIV tests during pregnancy in all your prenatal services?
We follow all ACOG guidelines, yes.
Right, okay, so that part you really do have covered, and it's pretty easy. To jump right into universal is sometimes challenging, but I think we could help you to focus on, my particular area is women and HIV, so maybe we would be able to talk about some targeted strategies for HIV testing as you're moving toward universal.
That's great. We have 2 OB sites currently, and we'll have another expansion to our East Valley Mesa new health center that'll be open in late October of this year.
And if your OBGYNs are not really totally familiar with treating women with HIV, there's a special component of our training package that deals with those issues. So you might not have thought about including them, but there would be definitely a role for them.
It might also depend upon the volume that we see. Once, we do more of this, it might be hard to convince the OBGYN docs to get involved in a lot of training if there isn't a population for them to be treating. So,
Sure.
Yep.
Yeah, we'll talk about that. Okay.
Yep.
It's understandable. All right. Well then, just as next steps,
what we're going to do on our end, there are a number of people on this call, but in the next couple of weeks, we're going to assign a coordinator to you, along with a clinical coach and performance improvement coach, and those people will really be working with you throughout the year. And then, as Mona mentioned earlier, on the clinical side, we are going to do a second call with you to help you have a better understanding of the HIV training package and what we have to offer clinically. And during that call, we'll also go over the second level of individual assessment, the self-assessments that your providers that you identify for your care team will be involved with. And then that should cover, and this is not in any particular order, right, as you see on the screen. It seems like the next call will be in March 13th or 12th, but you're going to get back to us and see if either one of those dates works. And if they don't, we can make sure that we arrange a time to speak with you individually.
So can I just interrupt there for a moment? I just want to be absolutely sure what I'm checking on here. I don't think that 10 a.m. on the 13th could work, since it would be 7 a.m. our time, but
right.
The noon on the 12th would be 9 a.m. our time, and how long do I need to plan for on a call like that?
Up to an hour.
Okay, great.
An hour, and if that really is inconvenient, I'm serious when I say that we can work out a time that is better for you, and perhaps we could spend even longer if you thought that the need was for more time.
That would be really helpful, I think, because our clinic opens at 7 a.m., and so for me to pull the doc out at a specific moment in time once we've started is kind of hard, as you know. So maybe scheduling something that, is more our time. But let me talk to Dr. Soto and figure it out first, and I'll get back to you.
And on most days, it's not a problem at all for me to take a late, what's late our time, to take a late call.
Okay. And so who should I get back to once I figure out our
I'm going to send you an email. I'm going to send you an email as soon as we complete this call.
Wonderful. Thank you.
All right.
And then on
the meeting, when it is and who should go.
She's coming down the list here.
Are we moving through these next step bullets and we can talk about the community meeting?
Yes, we are.
Okay. I thought so.
Before we get there, I'm going to let NASDAQ or Vanessa talk about the next steps on the performance improvement side.
Sure. Similarly to the clinical side, for performance improvement, we're going to be working closely with the leader and assign you a coach. And within the next couple of weeks, based on this discussion, we're going to be submitting you all a draft set of objectives around performance improvement and work together to create a project plan to see how that work is going to get done between now and the end of December. We've also found that in terms of best practices, making sure folks stay on top of this work, that weekly meetings make the most sense for us, and so we're going to try to schedule that time. And it's not going to be with this team that we're talking to right now, but whoever's going to be working on the specific changes that we're going to be talking about. So we'll work with you all to figure out who the best people would be for those teams, and then to set up a weekly time for those teams, at least initially, until we figure out what works the best. Vanessa, did you have anything to add?
No, that's perfect.
Okay. All right, so I heard you guys talking about the community meeting and who should attend. So again, it is April 19th through 20th. We wanted each of the learning leaders to attend along with your CEO. Clinically, at the community meeting, we were going to begin working on your training plans, so it really is important that the clinical learning leader is present. And you should have received...
Just to confirm, we did receive an RSVP request, but it had different dates in there. I just wanted to make absolutely sure. Is it the 18th and 19th as the RSVP indicated, or is it the 19th and 20th as the PowerPoint here describes?
Oh, it is the 19th and 20th. You would travel.
Friday. Right, Thursday 19th, Friday 20th.
Right, you would travel, you would likely, especially since you're coming in from New Mexico, you would travel on the 18th.
Okay, so the RSVP date said 18th and 19th. I just want to make sure.
Whoops.
That would mean
we'll make that correction.
Okay.
No. It's not travel. It's the 19th and the 20th, absolutely.
Okay.
Yeah.
On the 18th and the 21st.
When does it end on the 20th?
The community meeting ends around midday on the 20th. We are also having, Health HIV has a national conference, Synchronicity, that begins at the same hotel that the community meeting is being held, directly right after that. So on the 20th through the 21st. And and of course, you're invited, as you saw in the RSVP form. You're invited, and if you choose to attend, your lodging and all travel expenses will be covered as well. And if you have any questions, feel free to contact me.
Who is that speaking?
I'm sorry, it's Christine Stewart.
Christine. Okay. We'll contact you, Christine, if we have any questions about the community meeting.
Yes. Community meeting or Synchronicity.
Thank you.
No problem. All right. So do you have? So it sounds like we'll be in contact with you soon. On the clinical side, we'll expect to hear back from you, Dr. Delk, just to see whether or not March 12th works for you and Dr. Soto, and then your coach on the performance improvement side will begin to contact you to start laying out objectives.
Sounds great.
All right, and I'd like to thank all of you for being able to attend this meeting. It's a pleasure to be able to meet you. Sorry we weren't able to come meet you in person, but we do look forward to doing so during the community meeting.
Thank you.
We look forward to working with you. Thanks.
All right.
Thank you.
Have a wonderful day.
Bye, everybody.
Bye.
Bye-bye.
Bye.